Right. Well, hello, everyone. My name is Kasey. I work for the EMS for Children Innovation and Improvement Center. I'd like to welcome you to today's Pediatric Readiness Recognition Programs Collaborative. This is our first session post our kickoff during the all grantee meeting. So I welcome you all and excited to hear from you today during our session. Would like to first start by saying that the EMS for Children Innovation and Improvement Center and the Pediatric Pandemic Network are supported by the Health Resource and Service Administration, also known as FACEP, which is within the U.S. Department of Health and Human Services. The contents of those are the authors and do not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. And thank you all for joining today's session. It is being recorded. Feel free to add all of your questions throughout the presentation into the Q&A feature or the chat feature. We'll have time to address these at the end of our presentation as well as throughout today's presentation. Today's presentation is meant to be interactive, so we look forward to engaging with you over our next hour and a half. All right, and here are today's formal objectives. I want to begin by reintroducing the PRRPC team. And this is in addition to support from Margot and Morgan during the planning stages of our collaborative and the continued support from our communications team and other subject matter experts. It was great to meet with a lot of you during the all grantee meeting. We hope that you also had a chance to connect and collaborate with each other during that time. We do have 51 participating states and territories in this collaborative. You may recall that during the environmental scan, we asked each state and territory to report their current phase of development. And here you can see the results of that question. So for on the top quarter, we have our ED recognition programs and the current phases. So that's going from phase 0 to phase 5. And then below that, we have our pre-hospital phases recognition. So we are excited to look forward and watch how this progresses as we move through the collaborative. And a reminder, the goal of the PRRPC is to work with all participating states and territories in developing new ED and pre-hospital recognition programs, as well as to incorporate key recognition criteria and to support the expansion of recognition programs. As we get started today, I'm going to hand it over to Dr. Remick.
Awesome. Thanks, Kasey. Good afternoon, good morning, depending on where you all are. Great to see everybody. As you should have received an email from us, we know that there was a lot of comments, uproar, in some cases enthusiasm, I guess, for the attention that pediatric readiness recently got in the news. I know particularly among many of you, there were a number of inaccuracies that were noted in the Wall Street Journal article. But we'd send an email and really wanted to make sure that there was time for people to really talk about that. We did not want to spend the whole session focused on it, but we did want to at least draw your attention to it if you are unaware of what was in that article or what's happened subsequently. So if you could go to the next slide, please, Kasey. This is just a snapshot of the article that came out from the Wall Street Journal. This happened, gosh, I believe it was now about 3 weeks ago. I think it was the Sunday after the all grantee meeting. And the title of it was "Children Are Dying in Ill-Prepared Emergency Rooms Across America." For those of you who read this, you know it was a recount of many of the deficiencies that currently exist in our emergency care system. And in addition to that, they highlighted 2 very sad cases of 2 children who are pictured here at the front cover of this particular article. Subsequent to that, the Wall Street Journal also published an article in association with that of what they deemed to be the 14% of U.S. emergency departments that they stated were certified as pediatric ready or specialized in kids. Now, I want you all to know that we were certainly very aware that this Wall Street Journal article was coming out. We had zero to do with commissioning it. This was something that they came about all on their own. And what we do know is that they spent probably 6 months or more interviewing, reaching out, and talking to a number of people all over the country, from some of you to folks both within the EIC and the MSC Data Center. We know they reached out to a number of individuals at FAAP proper and other organizations. You'll see quotes within this article from the American Hospital Association and a few other entities. We did not provide them with any kind of list of what emergency departments were pediatric ready or certified. This was something that they did entirely on their own. And if you're wondering about the algorithm that they used, what we understand is that the way they decided that these emergency departments were so-called ready is that they were either, in their estimation, children's hospitals, pediatric verified trauma centers, or however they came up with this list, pediatric ready recognized facilities by our EMSC state partnership programs. Now, I don't really know the extent of how they came up with this list. I don't have anything to say about how they came up with the algorithm either, but I want to at least explain to you all so that you would understand kind of where this list came from, and you can speak to it if you get any questions about it. If you could go to the next slide, please. Following on the heels of this Wall Street Journal article, it was picked up by a lot of other media entities. And you can see this running list of blogs, other newsworthy notes. Some were videos or interviews. You can see some are in YouTube. One that you might want to be aware of in particular is the one that was created by Becker's Hospital Review. It's the third from the bottom. Sorry, the sixth from the top. It's the best worst states for ED pediatric preparedness. And the way that Becker's Hospital came up with this was the percent of hospitals that had been recognized by or identified by the Wall Street Journal. And so they categorized every state by the percent of hospitals that they had, that Wall Street Journal had stated were certified as pediatric ready. So you'll see a list of states, less than 5%, more than 5 to 10%, et cetera, et cetera, et cetera. It was also picked up by Apple News, and we don't really know the degree or the extent to which, and we're happy to share these links, Rachel, the degree or the extent to which Apple News receives certain amounts of attention. What we do know is that the Wall Street Journal article in and of itself received about 115,000 hits on its own. So while there were certainly not 100% accurate in their reporting, and we'll talk through that, it did bring about a lot of attention to the work that we do in trying to improve our emergency care systems for children. So we'll work on getting these links shared with you. If you could go to the next slide, please, Kasey. What I want to just highlight for those of you who maybe couldn't access the article, because we know it was for those who subscribe, or maybe forgotten some of the big pieces, just some of the highlights from that article. First and foremost, I would say that it tended towards a more negative perspective than a positive one. It certainly highlighted deficiencies more than it highlighted progress. And I know all of you, many of you have been working on pediatric enhancements in our emergency care systems for decades or longer. And in some ways, when you read this article, it maybe feels a little bit unfair or biased that what they highlight are the deficiencies and maybe not all the work that has been done to try to move this forward. As I mentioned, they also highlight that 14% of EDs in their estimation are ready to treat children. And again, that's their definition that they used. The third is that they do highlight that a lack of readiness is associated with lives lost. And I think this is important and probably one of the most impactful pieces of evidence that they share that's really helping to promote increased attention around this issue. They did share the median score. They shared the threshold that 88 plus is associated with being well prepared. And they said that neither improvements made nor efforts implemented were really well recognized within this article. So they talked about the current state, but they didn't talk about the history or the efforts that have been done more broadly aside from the recognition programs that currently exist. If you go to the next slide, please. Within this article, I would say that there were some truths that they really did highlight or uncover, and I think these are important because we should all know that this is what was shared, and I personally believe these to be generally true, and I think it was important that they were stated, so I'm just going to read these out. So the first being that when they described these two cases, they talked about how there are many EDs that lack pediatric specific protocols. And we do know this to be in fact true. We know this from the national assessment data. We know it was a challenge when they were managing these two children that they highlight. They also highlighted that many EDs lack access to either a pediatric crash cart or critical equipment. And this was really described when they talk about a young child named Avery in this article who was suffering a severe seizure, and they were unable to manage her airway. And there were questions about, was it lack of knowledge, lack of access, lack of skill? But we do know that this is indeed the case, and they made this statement that many EDs lack immediate access to critical pediatric equipment. They also highlighted that there is not a lot of transparency that allows parents to make informed decisions about where to take their children. And I think this is important, that there's awareness that the public really doesn't know much about pediatric readiness. And many of you have heard this a number of times from Mike Girardi, Steve Krug, many others, Al Sacchetti. But when a sign says emergency, to most parents, it means they can handle emergencies. And it doesn't qualify that, you know, any emergency besides pediatrics. They did highlight that there are requirements to be designated as pediatric ready, really speaking to our pediatric recognition programs, but they said that the requirements vary significantly. And in fact, they said they went so far as to say that some only require that they take up the assessment and create a plan. And I will tell you that this is true of the current ACS standards that have been set forth, is that they take an assessment and they create a plan to address those gaps or deficiencies. But I think this is an important point that we should reflect on as part of the EMSC community. They do also say that all EDs can be ready. And these are steps that you can take to get there. They highlight that child emergency care in general is underfunded and under-incentivized, which we all know. And yes, certainly, Dave, we can give you access to these slides. And then lastly, that CMMS and the Joint Commission currently lack pediatric specific standards that really call out the needs of children, and that there's a real opportunity there. And in fact, I think they really called out these organizations. And since this time, I will say one of the benefits is that the Joint Commission has regained their interest in some pediatric readiness efforts. So next slide, and we're going to give you guys a chance to comment. So feel free to kind of take this in. The next couple of slides are on the inaccuracies that we know some of you shared with us, some that we've just are aware of. But here are some of the inaccuracies. Not all pediatric ready sites are listed. Some are missing or simply inaccurate, that what's identified as PEDS ready may not be. They stated somewhere in there that 25 states don't check pediatric preparedness. And that was not, I think, the intent of the statement, although makes it look like 25 states, not named, don't take the pediatric readiness assessment, which is not true. But that, I think the intent was that 25 states aren't the authorizing body over ensuring or assessing pediatric readiness. They said that recognition is based on the weighted pediatric readiness score alone, which is not true. They said that from the AHA, this was a quote, "It is unreasonable to expect every ED to have the pediatric expertise of a state-of-the-art children's hospital." And I think the inaccuracies of this is that pediatric readiness isn't about state-of-the-art care, and it's not about being a children's hospital. It's about being able to immediately stabilize, resuscitate, and manage a child. The last bullet here is that EDs aren't ready because government agencies and professional societies haven't required action. And I would say that is entirely untrue. In fact, it is the professional societies like AAP, ACEP, ENA, ACS, et cetera, that have required action. And when we think about government agencies, it is actually many state governments, such as the ones that you all are housed within, and the MSc program that has really spoken out for action to happen. So I think these were some of the top inaccuracies. And then if you could go to the next slide, just a few more. They stated that EMSC programs are using their funding primarily for staff and training only, which is not true. I know many of you are doing far more than that. They said that pediatric trauma centers are intentionally limited in number to ensure that staff see a large enough volume of patients. That also is not true, although there are volume requirements. They said that only Tennessee, Illinois, and New Jersey require all hospitals to be pediatric ready, and there were some caveats around Illinois and EDAPS, which has some inaccuracies affiliated with it. And then, of course, that 22 states have recognition programs, and we hover and waver around this, but there's so many states and territories that are working on these recognition programs that have made great strides. And so we wanted to share these with you. So if you go to the next slide with that, I'm going to turn it to Rachel, who's going to kind of share and lead a discussion around this.
Yeah, so thank you so much, Kate. We just wanted to open the floor to everybody, and would love to hear from you verbally rather than in the meeting chat. So first question for our open discussion, were there any other inaccuracies, if you were able to read the full article and even look at the database that you recognized as you went through that Kate didn't provide an overview of? And please feel free to just speak up.
This is Phyllis Hendry from Florida. The only thing I would say is, I guess they were only doing ACS verified trauma centers, but many states like mine have state designation. We also do ACS verification, and I wonder if they understand that level 1 trauma centers are capable of taking care of children and adults. And then I found it interesting, Florida has at least 17 children's hospitals, but I think we only had about 7 or 8 dots on our map. So I'm assuming they only did ACS verified pediatric trauma centers. I don't really know where they got it from, but I don't even think they captured all the children's hospitals. So I just wonder where they got that list from.
Yeah, I think, it's not clear to us how they got that information. I'm thinking a lot of it was just scouring web pages and what they could find on state websites. But yeah, unfortunately, as Kate mentioned, we really don't know how they populated that database.
This is Also very similar to a lecture I put together like 20 years ago, and it was the cover of Time magazine of the child, the shame of emergency medicine, pediatrics. It's almost like they just repeated the same article, but used the term pediatric readiness. So we have been through this before for those of us that are older.
Yeah, that's right. Thank you, Phyllis. Anybody else on inaccuracies or concerns?
That's Dwayne from Pennsylvania, and I'll just note, and I'm sure Pennsylvania's not the only state that they did, I pushed this up to the state media for the appropriate level of response, and they did not reply to the inquiry. And I'm sure there's more than one state that did not reply, and therefore the information was left for the Wall Street Journal to dig into however they did. They can look at ACS verified in Pennsylvania. It's not going to come up because they're not an ACS verified state. But one of the things in conversation with people from the Department of Health and from my own organization was, look, how can we take the good from this, that they're bringing awareness to it, and we can point out the inaccuracies of the article to dispute some things they're saying, but we can also point out the importance of what we can glean from this and how we can use it to promote the movement, the forward movement, and even a quicker movement of pediatric readiness to the degree that we can within the state or nationally. And I know that's a kind of a tricky angle, but I think at least at the state level, at the state partnership level, we have a plan to utilize some of this information, both its accuracy and inaccuracies, to promote the need for the readiness initiative, whether it be activity or funding, and take some positive out of this.
So Dwayne, you're saying that when you got the journal request, you push it up to your communications people, and they're the ones that didn't provide a response to the Wall Street Journal?
From what I understand, that's correct. There was no response from Pennsylvania to the request.
Gotcha.
Whether it was timing or whether it was the decision made, within the media group for the Department of Health, I don't know.
Yeah. Okay. All right. Thanks. Yeah, I think that's gonna happen with a lot of folks, whether you're in the hospital system or Department of Health, that we can't always speak our truth, unfortunately. All right, well, let's move on to any benefits from the article's publication. I have heard, and I see both of your comments, Sam, that obviously disappointment in Michigan for not pointing out all that has been done. But now that your program has kind of been highlighted, seen a little bit of positive outcome from that. And I think you mentioned that as well, Dwayne. Any other additional benefits from people that you'd like to speak out about?
This is Carrie from New Mexico. Unfortunately, at least in my state, it did start a few discussions that has been able to open a couple of doors that weren't open prior to this article coming out. Mainly it was a lot of why hasn't EMSC come in and talk to us about this and stuff like that. We were able to say, well, on this date and this date, we sent you emails and visited you and asked for time and weren't able to get it. So, but these were hospital systems that are nationwide. And I think the pressure was from a corporate level that they weren't being seen as being proactive in their communities. So it's opened a couple doors, at least in New Mexico.
Great, thanks for sharing, Carrie. Any other thoughts, both either positive or negative? So Amy's shared a couple, the FAQ we put together that hopefully folks have been able to direct people to, as well as a recognition program page. Are there any other resources or things that the EIC can do to support you in responding to any of the backlash that might be coming out of this?
I thought I had heard that, I know the outgoing president of the section of PIM for ACEP was asked to write a rebuttal. And then I thought I heard somewhere, are the different organizations working together to send a message, or is each organization sending their own response?
Emily Lemeska, can you speak to that?
Yeah, so thanks, just been listening in and really appreciate everyone's thoughts and comments here. So we are, the EMSC provided some technical support in drafting an op-ed that AAP, ACEP, and ENA have reviewed and are signing on to, and that we will be submitting to the Wall Street Journal either on today actually or tomorrow. So it took a little while to align on our messaging and strategy, but that response will hopefully be published soon, and we can definitely share it once it's out with all of you.
Thank you, Emily. Sam's question: if health systems leadership want to talk to EMSC higher ups, who maybe direct them to? Yeah, they want to talk to bigger people than the state. I hear you, Sam. Kate or Emily, how can we direct that question?
Yeah, I mean, Sam, we can certainly help to try to direct them. I guess it depends who they're most interested in speaking to. Emily and or myself are happy to kind of take in some of the asks, and we can help to distribute them. I know there's been individuals who've specifically wanted to talk to leadership at the EMSC data center about the assessment. There's been folks who've wanted to talk to the Bureau. I think it just depends on what the ask is, but happy to help you sort through those requests.
All right, well, don't want to belabor this point if everybody's said what they feel like needs to be said. So Kasey, I think I'll hand this back over to you. And as always, if anything does pop up that's a little more time sensitive or something we might not have touched on today, please don't hesitate to reach out to any of us on the EIC team, and we'll do our best to work with you and get you what you need. So thank you so much, and take it away, Kasey, with the key takeaways. Or is that Kate?
Well, if I could just make one quick comment, Rachel, I just saw Jess Davis's comment in the chat, and Emily can speak to this too, but it's been really challenging in terms of the tone of the so-called rebuttal, and it may be best to not call it a rebuttal, because if it is, it just seems to look very defensive, and this has been a very fine line to walk. But Emily, do you want to kind of speak to the tone of this so that it has the greatest impact?
Yeah, so I think, you know, it's definitely a little bit of a tightrope to walk. And I know Kate shared the list of pickup we'd seen from other media outlets, but we honestly didn't see it get picked up as much as I thought it might be. Like, none of those outlets were really other huge national outlets, for example. So we do want to be sort of careful in like giving it more life and legs than it necessarily needs. And there's also just, you know, of course, a lot of, you know, wanting to be more proactive than reactive, because sometimes that can just spiral into more negative coverage. The Wall Street Journal could respond back to us, and that could just kind of add fuel to the fire. So the response, the joint op-ed, is very much sort of trying to find the positives and trying to create a call to action for folks and saying like, okay, we know there are problems, but we've made a lot of progress, which was kind of missed, and really ultimately emphasizes, you know, that we need more support and resources, and we need everyone to get involved and rally behind that. So so I think more of a, you could say, a response, not necessarily a rebuttal, but just wanted to share the strategy behind that.
Thanks, Emily, for sharing that.
Right. Thank you, everyone. Again, if any needs come up or you need assistance, hopefully we can point you in the right direction or connect you to the right person. Just be reaching out and let us know how we can support. But we did want to make sure we provided that space today, and if there's anything else, let us know. But a few key takeaways from that would be, we want to recognize, we know the importance of our work. Our resources are limited, but our efforts will continue. Our team is growing, expanding work and awareness. Through this, our voice is getting louder, and we know that pediatric recognition can be successful and leads to success. All moving in the positive direction. I think that's a great message to continue to reiterate. And we back at why pediatric readiness recognition programs matter. Based on the 2021 Pediatric Readiness National Assessment results, did show that EDs participating in recognition programs had a 24 point higher median score on average than the emergency departments that did not. That is working in the right direction and has a good impact on pediatric readiness. And our key takeaways: we know that pediatric readiness and recognition is important to not only families, but policymakers and healthcare leaders. The impact of our collaborative: we need to align our efforts, leverage this increased attention, and see how far that can help carry our message. We identified a lack of transparency regarding pediatric readiness, the emergency departments and their scores. This will eventually need to be highlighted. Those EDs who are recognized and can stand behind our criteria. I don't know, Kate, if you want to speak a little bit more to that transparency point.
Yeah, I mean, I think what this article did highlight is that it's difficult for parents to make informed decisions. And I think collectively, it would be nice if we could move towards greater transparency to help families understand this. But we know that we can't share scores alone, that those are would really be at this juncture a breach of confidentiality for those sites. But there are ways that we could eventually create more transparency. And I think this is something that we may circle back to in the future. But at this juncture, there are things we can focus on. And so if you could go to the next slide, as we begin to really, collectively unify our efforts, what we hoped we could do today is really hit this center point: is what can we focus on that we both have the ability to control and that we know will make an impact. And I think that's where pediatric recognition programs are exactly that. And if you could go to the next slide, for those of you who know Stephen Covey, 7 Habits of Highly Effective People, and other books, he talks about this circle of influence and where we can really focus our efforts as opposed to focusing on all these, this external circle of concern, which is, all the problems. And so what, I think was highlighted in the chat is this agreement that we should move in the positive direction and really take hold of this opportunity. I think, as Sam said, make lemonade out of lemons, and figure out how we can move this forward. So with that, what we hoped we could do with you all today, and this was something that was done in the first Pediatric Recognition Program Collaborative back in 2014, which is really how can we get to consensus on what are the most critical or meaningful criteria. You heard in the Wall Street Journal, they highlighted that our programs are variable in terms of criteria. And because of that, there's a question of, is every program equal? Obviously not if the criteria are different. And so how do we as a group go about establishing meaningful criteria that are somewhat standardized in approach? And this is not a requirement. This does not mean that you must or have to adopt these, but it's an important exercise to go through is, can we as a group come to consensus on a set of minimum acceptable standards for pediatric recognition, standards that would be meaningful to the public, standards that when we stand by a hospital and say, yes, they're pediatric ready, that it means something not just to us and the hospital, but also to the families who choose that place to take their critically ill or injured child. So we hoped we could go through this process with you all today, which is really a consensus-driven Delphi process. This goes through several rounds. Today would be essentially round one. And then in the future, we'd go through a second round of really looking at those criteria, reevaluating them individually, coming back as a group, and go through several cycles until we get to consensus on what should the minimum acceptable standards be for pediatric recognition in the emergency department. In the future, we would hope that we can use a session similarly to look at EMS recognition criteria, and also to look at some of these other aspects that I know you all are interested in. One that we just talked about, which is transparency of those recognition programs, the pros and cons of tiered systems versus single systems, the process of verification, and how we go about application. So all of that is really planned in the future of how we kind of move collectively towards, the most successful and effective programs, both in the ED and EMS. But we hoped we could spend this time today, at least initially, to focus on this process. So if you could go to the next slide, I'm just going to kind of highlight what this would look like. Unless there's significant opposition, I would like to propose that we go through a process of trying to get towards establishing minimum criteria for ED recognition. What we have done is we've pulled out all the criteria that are currently being used by any pediatric recognition program. We'll talk a little bit about the data behind them, discuss the pros and cons, and everybody who's on this call will then have an opportunity to vote. Should this criteria be up for inclusion in minimum criteria? Yes or no? It's a simple yes, no. If you agree, then it'll move into round two, where you would then have an opportunity to begin scoring these criteria. Are they differentiating? Are they achievable? Are they important in terms of outcomes? And we'll aim to go through essentially 3 rounds of voting to get to minimum criteria. So with that in mind, I'm going to pause and see if anybody has questions or concerns about this process. Okay, hopefully it'll be helpful. So with that, I'm going to turn it over to Michelle Megling, who's going to kick us off with the first round of criteria. So Michelle.
Thank you, Kate. Let's look at some of the ED criteria. So go next slide, please, Kasey. So we know from our ED recognition programs, and thank you, Kasey, for putting all this together, where we have the most commonalities, to call it, is having one PEC, looking at disaster plans that have considerations for children, and also including pediatric policies, procedures, and protocols. Or those are our top 3 that are common between all of our programs currently. Weight in kilos for pediatrics comes down in number 4. Pediatric equipment, supplies, and medication, really having written pediatric interfacility guidelines, and then QI plans. Some of our lowest ones that we see commonality are minimum pediatric readiness scores, mental health policies, written pediatric interfacility agreements, evidence-based clinical pathways, competencies, and then reporting of pediatric patients' weight in kilos. seems like a couple of these cross both sides. Next slide. So minimum criteria set by the EMSC performance measures included a minimum of the following elements in the highest tier. Effective performance period, this is for April of 2024. Looking at PECs, a nurse and a physician PEC designated. Disaster plans, having the presence of disaster plans that address the needs of children. And then weighing and recording pediatric weights in kilograms. As we know, that can cause serious safety events. Next slide. So we know that PECs are one of the strongest drivers of improved pediatric readiness. The presence of a nurse physician dyad has an average 16-point increase in the adjusted weighted pediatric readiness score. The PEC improves all domains of readiness, but is really most associated with improving quality improvement, because usually it's the PEC that's leading pediatric quality improvement in the emergency departments. We also know that only 28.5% of EDs have both a nurse and physician PEC.
So Michelle, could I just quickly address Dwayne's comment, because I think it's a really important one?
Yes.
By way of process issues. So we know not everybody in this room, virtual room, represents every voice within the creation of these programs. And but our goal is to get to consensus among the leaders who know these programs best. This is merely the first round, Dwayne. And so what I would suggest by process, and would love to hear your feedback and others' feedback, is if there are critical voices at your state level who you want to participate in this, then we can include them in round 2. So this first round 1 is simply yes or no, should it move into round 2? By those of you who are in this room, which is about 50 people or so. And then round 2 would be a scoring and further discussion. Would that serve your needs, Dwayne, in terms of meeting the voices of all critical representatives? Because much of that will be done offline, the round 2.
I get the purpose and I don't disagree its need, but I am weary about setting some priorities that might not all be in line with what at least I'm trying to work with a representative stakeholder group in developing the program in our state. And knowing our program is set up and structured differently because of how it is defined within regulation and grant and everything, that not everybody's the same. So we all have a little different process. I don't have a problem voicing what I feel is my opinion of where the program is going, but I just wonder if it's something that need and should be done now, or do we digest this and do this after the fact in a very short time frame in order to move it forward timely and expeditiously, but at least have some process of some time to process the information. It's a singular vote versus a feedback from whomever is working on the process within each of the state partnership programs. That's just my concern. That's all.
Yeah, I mean, I will say that today is definitely not getting us to a final vote. And I would say if you are worried that criteria will be excluded, I think it's the goal in this first round is to err on the side of caution of, do you think it's reasonable to include it in the next round? The other thing that I would say is that typically the way a Delphi process is done, just to address Pat's comment, is it's typically subject matter experts who are providing the guidance around criteria. And to try to involve facilities themselves, there are 5,000 emergency departments, all with different sets of resources, all with different levels of buy-in. And we wouldn't even begin to know like which individuals we should be pulling in. So it's really about those entities that are going to be overseeing the actual program that you're developing. And as EMSC state partnership managers, you all work every day with folks on the front lines in rural communities, critical access hospitals, et cetera. And what we're talking about is the bare minimum criteria, not the highest tier, the bare minimum that we think is potentially achievable for any facility. And if you all don't think it's, something's achievable, then you vote no. But this is far from the final process. It's usually multiple rounds. And based on what you're saying, Dwayne, I think that we would probably get to perhaps 4 or 5 rounds within this process before we get to consensus. Because if there's significant variability in the votes, then that means that we're still not at consensus around them. And we need to continue to move on and carry on the discussion and understand why. So every step of the way this works, this is just the first round. Should these criteria be included or not? Are they part of what we consider to be important for pediatric readiness? And then the next step is everybody who you all feel should be part of your core team will then get a list that they get to assess every single criteria individually in the absence of anybody else. It's their voice alone. All of that information then comes back together and gets compiled. And what we would do with you all is show you how the aggregate scores of every single measure according to everybody who's voted. There will be opportunities for discussion. Things that are ranked very low would be thrown out. Things that are ranked higher, there'd be a cutoff, will stay in, further discussion. And then again, every individual person leaves, ranks, scores these criteria individually. We come back together until we get to consensus. So the consensus doesn't happen in a room with everybody there. It actually happens by each person individually and then coming back together and talking about those results. So there will really be a lot of touch points. And I don't know if anybody else in the room has experience with the Delphi process and would like to speak to it, but would love to hear others' thoughts about this, if we should take this first step, or if maybe we just consider everything as yes at this juncture.
And I think Josh had a question too. Is this just focused on ED criteria?
At this juncture, yes.
Yes.
Yeah. EMS would be a separate session. I think the problem that we're trying to address is that right now, every program has different criteria. And so is there even a core set of criteria that we can agree to so that if on a national scale, we say a pediatric or a hospital is pediatric ready, that we all have a singular definition for bare minimum for that. Not that every program's the same. Some states will have multiple tiers, some will have single tiers, but what is the bare minimum that as the subject matter experts, we feel should be included? And we will not get there today. Dwayne, does that address your concerns, or are you still concerned about the process?
So I don't want to hog the time, but if we're talking bare minimum, I guess me personally, I go back to the list of the criteria, the toolkit, and the seven domains, the 7 topics in the toolkit, and that's what we're working off of, because I thought that, in a sense, was the bare minimum to start with, and where a facility can meet to what degree each of those. Do they have a nurse PEC? Do they have a doc PEC? Do they have both, for example? Or, with equipment and supplies, what are the minimum? And actually, just this past Monday, introduced that conversation to the development stakeholder committee to start to think out. So if we're talking about bare minimums versus requirements, yes, I think that's a good method to go, starting point, so that we all have that entry level and then can build from that.
Yeah, and that's what we're talking about is bare minimum, just to be clear. And the The HRSA requirements for recognition, let me just clarify Jess's question, have more to do than the actual criteria. It's more about how the program is implemented, and we'll get into that. It has to do with like verification, application, all these other components. But what we're talking about is bare minimum. The reason this is important is some states, their bare minimum might only be, for example, a pediatric readiness score and nothing else. And the question that we would have for you all is, what is the consensus around this? So if we just focus on ED today, we will focus on pre-hospital in the future. Yeah. And I think, Rachel, to your point, Rachel Ford, it's really important to have everybody in the room, even if you're focused on building your, let's say, pre-hospital program, it's still critical to have your voice on the ED side and vice versa, because at one point, you're going to be working on both at some point. But I understand the concern with times. Heike, were you going to add something, a comment?
No, I'm good.
Well, I think we should move through this quickly, and we can let you know, Rachel, when we do the pre-hospital one.
So next slide. If nobody else has any questions right now. So criteria 1, when we talk about PECs, do we think you should have at least one PEC? I think on the survey, 95% of hospitals that took the survey had at least one PEC. Or number 2, do you think you should have both a nurse and physician PEC? And I think that was a 28.5%. And Kasey's going to bring up the survey for you guys to vote.
And again, this is bare minimum criteria. What do you
Yes.
think is bare minimum that any hospital, regardless of their resources, should have in place?
And do you want us to have any discussion before this, or this just strictly based on what we think now?
We can certainly have discussion, and I would encourage you to bring that up, Phyllis. So please comment.
Yeah,
Absolutely.
so I think with EMS, it's much easier. You know, you have a medical director and everything reports to that, and they're licensed usually by your state. But our hospitals and EDs are a disaster. You know, you have all these hospitals are merging together. And I feel like what I see in Florida, I think it's going to other states, there's a little bit of a disconnect between kind of your nursing and hospital leadership and your physician groups. We have physician groups that have been in business for, 40 years. Private groups are now being bought out by all the big mega groups. And I think they can say they have a physician PEC, but are they really doing anything? So I just think it's a little bit of a different animal. I think it's going to be harder for EDs, to do this, just because of what's going on in the House of Medicine with all of these mergers and acquisitions. So that's the only comment I had.
And there's some other comments in the chat.
Yeah, there's a lot of comments in the chat. If you could use the voting buttons, I don't know, do you guys know how to do this? Are you seeing this?
I'm seeing it, but it's hard. To me, the questions are a little bit. Okay,
So-
I get it now.
You
Okay.
understand it now?
So you
Yes.
could answer no to both, yes to both, yes to one, no to the other, whatever you think. Yeah. For minimum criteria.
Okay. Has everybody had a chance to vote? Okay, let's move on to the next slide.
And we'll share the results at the next session or the next time we talk about this. So what you'll see is just you just put in your answers, and then the results will be compiled and shared with you.
Yeah, you won't see anything. When we look at disaster plans that include pediatric components, Loss of pediatric units, which has really resulted on increased reliance of general EDs to manage kids. Children are disproportionately impacted by disasters. We know that from last fall with the triple-demic of COVID, croup, and bronchiolitis all hitting at the same time. Climate change and human-caused events. So we know there's been a lot of, with climate change, some disasters that really do impact children as well as adults. And then 47.5% of EDs report a disaster plan that does include children. And this is an EMSC performance measure as well. Just highlighting our EIIC disaster checklist. Next slide. So for criteria number 2, disaster plans that include children. Disaster plan must call out pediatric considerations. And number 2, disaster plan must include pediatric considerations and highlight critical domains from the checklist.
Can you remind us what the critical domains are?
There are 11 critical domains.
There are 11 domains, coalition
Believe.
building, pediatric disaster champion, reunification, triage, decontamination, infection control, addressing children with special healthcare needs, drills and exercises. There's a few others, but that at least gives you kind of so the call out critical, oh, I see. Vicky's asking call out pediatric considerations means.
Yeah, like all of them or some.
So, and we'll get to some of this more in further sessions, but this is the first question is, should a disaster plan be included as minimum, period? And if you think yes, for sure, then do you think it should go even a step farther and actually call out some specific domains? And we'll get to that and through that during the Delphi process.
Thank you, Kate.
Yeah.
So if something is voted to pass for this minimum requirements, we're going to need to revise our program criteria to meet this, since this will be sort of the public facing idea of what a minimum pediatric ready facility looks like.
It would be a highly suggested minimum. Okay. It doesn't mean that you must. It's just a consensus driven approach to what this collective community believes should be the absolute minimum. And it might help to push your advisory committee in one direction or another as they think about their criteria.
Real quick question, sorry. If you are only on via a phone, how are you able to do the poll? It's not showing up. Is there something I need to activate or?
Swipe left.
Swipe left?
If you're on your phone by Zoom, you should be able to swipe to see the screen, and like Dwayne said, but if you're truly calling in by audio, then you may need to write your responses down and send them to Kasey afterwards.
Okay, thanks.
Any other questions? Everybody have time to vote on this one? Okay, I think we can go to the next slide. So weighing and recording pediatric patient weights in kilos. Children are 3 times as likely to have medication errors in the ED, especially when their weight is not documented in kilos. Weight and record in kilos is a national patient safety standard. It's also an EMSC performance measure, but we do know that not all EMRs are set up to restrict to kilos only. some scores improved in 5 of 6 domains since the last assessment. Weight in kilos was one of those. It was up by 49%, up to 75%. And this is really critical for, like, we noted the medication errors and making sure that we're giving appropriate doses. Next. So this is criteria number 3, weighing and recording children in kilos only. First question is weighing children in kilos only, which was 82% on our NPRP, and weighing and recording children in kilos only. So that's both weighing and recording for number 2.
Just for clarification, it's 82% of recognition programs that are currently in place have this as a criteria.
Thank you, Kate. I was speaking incorrectly.
No worries.
Anybody have any questions about this one or concerns or want to discuss?
I think we have a comment in the chat.
Well, Sam's comment, a lot of systems allow you to enter in pounds, but it converts it to kilos for medication. How do we account for this? Because it really doesn't weigh in kilos.
This is the rub with EMRs.
Yeah.
But we do know that many EDs have been able to successfully implement by getting scales that lock in kilos only. But you're right, the question is not, are we asking them to change their EMR? But there are these questions of, is this a reasonable expectation? And what's the impact?
Yeah, I think even Epic, you can enter either, but it converts it. So the medical record only shows kilograms. Hey, anybody else have any questions or thoughts on this one? I think I'm turning it back over to Kate next.
Okay,
Oh, Pete. Oh, go ahead. You want me to do this one too?
as you wish. Yeah,
Okay.
I mean, go for it.
Next slide, please.
I think there's one more comment about this one before we move on from Jess in the chat. Just saying, tweaking the wording. I think that's maybe something we can discuss in the next phase of the process.
Exactly. Yeah,
Yes.
we can talk
Yeah.
about verbiage and wording next phase for sure. So keep that on your list, Jess.
Pediatric equipment and supplies. Must have equipment immediately available to intervene. Many EDs lack pediatric crash carts. 59% of EDs carry 100% of equipment, and 92% carry at least 90% of the equipment. There is a cost associated with some of the items. Commonly missing items are McGill forceps, infant-sized non-rebreather masks, and pediatric difficult airway kits. You don't necessarily have to have a color-coded cart, but having some sort of pediatric cart is what we're talking about. And this really had a huge increase in the last survey, up 89%. And here are our questions. Should they have access to a pediatric crash cart in the ED? Is there a daily method to verify the proper location of pediatric equipment and supplies? All recommended equipment and supplies immediately available. and require critical, commonly missing pediatric equipment items. Kasey, just for clarification on number 2 and or Kate, are we asking that they're verifying that their emergency equipment or all supplies and
Yeah,
equipment?
it's the process of verifying the location of that equipment and
Okay,
so that they know where they are.
and that's for the emergency equipment. Okay, thank you.
Yeah, correct.
Give people a few minutes here.
It is shocking that many EDs lack PEDS crash cards.
It's scary. Okay, did everybody have enough time? Question from Josh about equipment criteria for trauma centers.
Did everyone answer, Kasey? So let's move on to the next one. So PEDS QI plans. So from the NPRP assessment, we know that having a full quality improvement plan is associated with an average 26-point adjusted increase in weighted pediatric readiness scores compared to having no QI plan. It is reportedly one of the top barriers, however, to pediatric readiness. There are now some measures that were suggested through NPRQI, and having a QI plan is intimately tied to the PEC rule, where we saw an odds ratio of having QI, if you have a PEC, is like 6.6. This is still very low among EDs, went from 45% to 50% over the last decade, but still a long way to go. So if you go to the next slide, Kasey. So the possibilities for criteria could be that you simply require them to have a QI plan. Do you feel like this should be part of bare minimum? Or do you want that to be more robust? Do you feel it should be more robust, that not only should they say, yes, I have a QI plan, but that they actually track pediatric specific indicators and performance, meaning that it's not simply chart reviews of sentinel events, but actually looking at pediatric specific performance indicators. Any discussion around this one?
I actually have a question on this one. And I don't know if it's something that can be answered nationally or if it varies state by state, but for instance, critical access hospitals, or any hospital, is it a requirement to have in your short-term acute care settings to have QI programs? And is that something that a critical access may not have, or is that just optional amongst all hospitals? Or I don't know if that question makes sense.
Yeah, so the Joint Commission requires QI plans, and they actually have certain measures that they've called out. Critical access hospitals, so the Federal Office of Rural Health Policy also has QI measures that they track, but none of them currently are pediatric specific measures. So,
Got it. Thank you.
And Kasey, let me know when we're at, I can't see. You may have to speed people up to get through the next criteria. So the next one are related to interfacility transfer. I think we actually have it on interfacility transfer guidelines and agreements. But as Michelle spoke to earlier, a lot of hospitals have closed their peds inpatient units. Data suggests that about 300,000 children are transferred every year in the United States, which to me is astounding. It's a huge number. Having agreements in place can reduce delays, help to identify the most appropriate facility that's closest in order to decrease the strain on families. There is potential that they could integrate this work into their quality improvement programs. About 2/3 of hospitals reported having interfacility transfer guidelines to help expedite this process. So if you go to the next slide, so these are the criteria. These are former EMSC performance measures having interfacility transfer guidelines and agreements. They're not necessarily current EMSC performance measures. You can see that 77% of recognition programs in place currently require transfer guidelines, and 68% currently call out transfer agreements. And the last thing I will say is that all trauma, ACS verified trauma centers at least, are required to have interfacility transfer guidelines in place, but they may not speak specifically to critically ill children, perhaps more trauma. And then Rachel, did you want to comment on that?
Just that they're not like performance measures, but you're still going to be reporting on them because it's part of the evaluation measure number 2 as whether or not you've got them in rules and regs.
Are you referring to a hospital has kind of their own internal policy about, you know, where they might transfer a child with a burn to? Or are you talking about having an agreement between 2 hospitals?
So typically the guidelines are the steps that you take in order to expedite transfer, call this hospital, et cetera. The agreements are typically between hospitals. So if, for example, you don't have obstetrical services, you know that this hospital has agreed to take those patients for you. So those are kind of ideally some kind of agreement that says, we know you don't have those services, we'll take those patients if you receive them. They're not necessarily related in terms of a business. They're just related usually regionally and have signed more or less like a memorandum of agreement that they will take those patients.
Yeah, it gets really messy with hospital attorneys. Okay.
Okay, looks like we had the votes. So next is around competency evaluations. As you all know, most EDs are considered low volume. That's where a large proportion of children are seen. And there are studies that have shown that most general EM docs report less than 1 pediatric intubation per year. Over 50% perform 0 critical pediatric procedures per year. What I want to just call out here is that maintenance of certification is focused on knowledge, not necessarily skills. But we do know that having board certification in emergency medicine is associated with increased overall readiness. You can see in the gray box those percent of EDs that require pediatric specific competencies for physicians, nurses, and or advanced practice providers. So a lot for nurses, less so physicians and APPs because of maintenance of certification, we believe. So the next questions related to competency. Do you believe that pediatric competency should be minimum criteria for all staff, for nurses only, or should they require more specifically pediatric skills practice? And you can answer yes to any or none. Kasey, where are we at in terms of voting? A few more.
And a couple more.
Okay. If people have comments, feel free to comment. Add your thoughts. Okay, policies and procedures. So these, this table may be difficult to see in full, but this is the table that was shared in the national assessment results, and those highlighted in yellow were specific policies, procedures that were called out that were somewhere below 80% in terms of number of EDs that reported having them. Just to follow on the left, the bullets. So having a validated pediatric triage tool, ENA has formally endorsed ESI. And this is one of the items that was found in some of Craig Newgard's work to be associated with increased survival, so early recognition. Mental health, as you all know, is one of the most common reasons for transfers and also one of the most common reasons for boarding. And about 73% of EDs reported having a mental health policy in place. That was a pretty significant uptick actually from 2013, probably because of the epidemic. Family-centered care, you know, we're so intimately connected with our FAN members and the importance of family-centered care, even in decreasing stress and reducing errors. About 2/3 of hospitals have reported those. And in terms of radiation exposure and meeting ALERA guidelines as low as reasonably achievable, about 76% of hospitals reported having guidelines for reduced dose radiation for CT and other radiographic imaging in children. So with that, and we called out interfacility transfer already in others, so those aren't called out here. These are ones that were specifically called out and reported in the assessment. So thoughts on whether it should be broad to say minimum criteria is that pediatrics are included in whatever policies, procedures, protocols you have in place, whatever you decide. More specifically, which is present in 86% of current recognition program criteria, whether they should have for minimum criteria some type of evidence-based pathways or decision support related to management of the pediatric population. That's present in 2/3 of current recognition programs. Presence of a pediatric mental health policy, which is currently required in 50% of recognition programs. And then the last three that were called out, we did not specifically ask about these, so I can't report on the percent of recognition programs that do or don't have these in our internal survey, but they're there for you to vote on. And if there are any comments people want to share. I think we just have one more round of criteria after this one. Close. So the last one is a minimum weighted pediatric readiness score. I think 23% of recognition programs require this, and you'll see that on when we move to the next slide. Some programs are using variable standards for what the minimum score should be. But in terms of criteria, what we know from Craig Newgard's work is that in order to achieve the survival benefit, the minimum score is somewhere around 88 or above. The problem with this being the only criteria I do want to highlight is that it could limit transparency of the program because of the confidential nature of the NPRP assessments currently. So with that in mind, the next slide is, do you feel, if it's meaningful criteria, that a minimum score of 88 or above should be required? And the reason we just put 88 here is that the others are not necessarily meaningful in terms of association with survival. So you can say yes, or you can say no. Are there any comments? Maybe someone's mic. Yeah, potential for inflated or inaccurate scores. How many more programs? Lowest tier includes this by default. Wording will be key. I think this Emily's comment gets to some of the earlier questions about, does that mean that these criteria will be what HRSA requires? The answer, or that these criteria are what HRSA require for recognition program? The answer is no, we're just trying to get to consensus. But there are other criteria that HRSA requires around, for example, actual verification. So a score might be reported, but truly be inaccurate.
Hey, Kate, can I ask a quick question? It's Michael.
Please.
You know, as I was filling out the poll in my head, I'm thinking about the studies and that this exact point you just brought up, that this is what predicts decreased mortality and all that good stuff that has been published recently. And I feel like I've answered the questions more in that angle of strictness. Like, I want this program to be really meaningful. Like, but I also at the same time don't want it to discourage those that are less capable of getting their scores up. You know, like, we have the evidence to say you really got to do these things and get your scores this high if you want to put this label on your hospital. Like, I know we're trying to set minimum criteria today, so I keep going back and forth, and maybe others are experiencing the same. But I kind of like the push. Like, I kind of want to push for excellence, not just participation.
Thanks for that comment. And Vicky had comments in the chat too that I think are similar. It's tough, but she says, you know, the score concerns me because our recognized hospitals have raised their scores because of participation. And if they don't participate because their score is too low to apply, then they lose their opportunity to actually help them raise their scores. And then another comment, we want facilities to be honest on their assessment without influence or pressure from C-suite potentially. And so all great comments. Thanks for that. Okay, so I think those are great. Again, minimal criteria. Yeah, excellence can be reflected in a tier-based program. Thanks for that, Sam. And there are two different angles to the same big mission. And then Dwayne said, I think a verification assessment by an independent surveyor may be valid, but not a self-reported score. So, you know, there are other maybe additional criteria that could be considered. These are some that have been used in other types of recognition programs related to outreach, education, policies, procedures, injury prevention, things like that. But I think what we're trying to do today is really get to the bare minimum. So to Sam's point, you can always tier and raise the bar on some of these areas. So with that, I'm turning it back to you, Julie. I know we only have 3 minutes. I'm sorry we took it the whole time.
Kasey, can you go to slide 56? We're going to come back and talk about a recap from the all grantees meeting and everything we did at a later time. But the discussion we just had was a lot more important. So we do have the electronic versions of the activities that we did during that day. And so we will get those out to you as well, and we'll cover those in future sessions. So if you will skip to slide 50, oh, perfect. So what's next? You can watch for the next round of the criteria consensus. So as we said before, we'll take the voting that we did today and the criteria that we looked at today, and we'll see what makes it to the next round. And then we'll send that out. If you haven't yet, please complete the session sign-up survey. So from our website, collaboratives at emsc.com. I'll show that in a minute. I actually don't know that off the top of my head, but it was Collaborative's website email address. You got an email a few weeks ago about completing a session. So this is, when do you prefer to present? So we want to hear from you in future sessions during the collaborative about the progress you've been making with your recognition program. We can learn from each other. We can share barriers, successes, so on. So we want to hear from you. So if you will sign up on that survey and let us know when it's going to be best for you to present. And then hopefully you are still working on your action plan and your SMART aim development for your recognition programs, whether you're developing the program or enhancing or expanding that program. We can still use that action plan. And then with that, we will see you at our next session on November 16th. We will continue this conversation. And also we have new resources for you. You can see that there are 3 QR codes at the bottom. We've got the Pediatric Readiness Recognition Programs. There's an updated map. We also have Pediatric Readiness FAQ page that was mentioned previously. And then we have our own collaborative page for the Recognition Collaborative, and you can go to this page and find many of the resources, specifically the resources that we gave you at the kickoff meeting at the All Grantees pre-conference session. Those are listed there. Kasey, did I miss anything? Does anybody have any questions?
Great work today, you guys. I know it was a lot going through that, but I think this is really an important step to get to consensus, and appreciate everyone's input on it, and we'll continue to move it forward.
And if there are any questions or comments, feel free to email us. Kasey, the collaboratives at emscimprovement.center. Email us, let us know your questions, concerns, what you need. And with that, thank you very much for your participation today. Hope everybody has a great day.